in our previous videos, we've been stating the classes of medications we use in managing hypertension, but we have not been diving into a deeper detail of how they work, what will be side of the side effects, what are the examples of medications in the different classes. So for this video, let us look at some of those things because you've been asking them in the comment section. So for that matter, let us dive into this pharmacological awesomeness. To start with, let us start with medications that affect the RAAS. These are some of the first-line medications used in managing hypertension. We are also going to look at some other classes, but to start with, drugs affecting the RAAS, the renin, angiotensin, aldosterone system. Let us first recall what is in the RAAS. Remember, the RAAS is one of the etiological mechanisms through which hypertension develops. What happens? For us to activate the RAAS, we should be having less sodium and chloride ions reaching the macula densa, an increased sympathetic outflow, and a reduced GFR. Whenever we activate the RAAS, we release a hormone, in fact it's an enzyme called renin. It's released by the kidneys. Yes, we have renin. Renin is an enzyme that converts a protein produced by the liver, a protein called angiotensinogen. So angiotensinogen is converted by renin to angiotensin 1. Angiotensin 1 flows in the bloodstream to the pulmonary circulation, where we have an enzyme called angiotensin converting enzyme. So here we have an enzyme called ACEi, angiotensin converting enzyme. Angiotensin converting enzyme converts angiotensinogen to angiotensin 2. You get. Also, angiotensin converting enzyme breaks down what we call the bradykinins. It hydrolyzes bradykinins. We are going to look at the role of bradykinins as we move forward, but it occurs in the lungs. We have conversion of angiotensin 1 to angiotensin 2 by angiotensin converting enzyme. But angiotensin 2 has effects in the cardiovascular system, in the adrenal cortex, and also in the kidneys. What are these effects? Angiotensin 2 has two types of receptors. You have the type 1 and type 2, but angiotensin 2 has a higher affinity for type 1 receptors, and they bind onto the blood vessels, causing vasoconstriction. So it causes vasoconstriction. Let us recall, like, blood pressure is equal to the cardiac output times the total peripheral vascular resistance, and cardiac output is affected by the stroke volume and the heart rate. Stroke volume is highly affected by the venous return, what we call the preload, and peripheral resistance is affected by the contractility and compliance of the blood vessels. So if we have vasoconstriction, we increase the peripheral vascular resistance, increasing the blood pressure. What happens in the adrenal cortex? In the adrenal cortex, angiotensin 2 stimulates the release of a mineralocorticoid called aldosterone. So this mineralocorticoid, in the filtrate flowing in the kidney tubules or in the nephron, we have sodium ions being reabsorbed under the influence of aldosterone. So we have sodium uptake. You get. So when you have sodium uptake, water follows by osmosis. So we have sodium and water retention. When you have water retention, you have an increased vascular compartment, have an increased venous return, we increase the cardiac output, thereby elevating our blood pressure. What else? It directly promotes the uptake of sodium ions and the excretion of hydrogen ions. So those are the effects of angiotensin 2. You get. So in the medications we use for managing hypertension, drugs affecting the RAAS have a direct effect on this etiological mechanism, and these drugs are of three types. We have the angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and the renin inhibitors. To start with the angiotensin converting enzyme inhibitors, they inhibit this enzyme. So the enzyme is inhibited at this particular point, so we will not be having angiotensin 2, therefore we won't be having any of these effects. The effect of angiotensin 2 on the blood vessels, therefore will reduce the total peripheral vascular resistance. We won't be having sodium and water retention, therefore we won't have an increased venous return. We will reduce the preload, we will reduce the cardiac output, thereby decreasing the blood pressure. Examples of medications that lie in this class: the first medication that was developed was captopril. Basically, they have a suffix pril. We have lisinopril, we have enalapril, we have fosinopril. Any medication that ends with the pril, those are the angiotensin converting enzyme inhibitors. What could be some of the side effects? If you're enrolling someone on this medication, you ought to tell them some of the side effects that may occur, such that when they occur, they know it's because of the drug, and when they occur, you ought to change the medication. One of the main side effects is a cough. Cause the angiotensin converting enzyme also broken down bradykinin. So if we have accumulation of bradykinin, they stimulate or they bring about a cough. In addition to that, bradykinins are potent peptide vasodilators. So they also play a role in management of the blood pressure because they are vasodilators. They decrease the peripheral vascular resistance. But because of this vasodilatory property, they cause what we call angioedema, because they stimulate production of prostaglandins, and in fact they are more potent than the histamines and acetylcholine. So we have angioedema, angioedema whereby someone gets like edematous, the lips have become very big and everything. Cough, angioedema, and since we are losing sodium because of an inhibition of sodium uptake, we will have hyponatremia, low sodium, serum plasma levels of sodium. And since whenever we absorb sodium we lose potassium, but since we have inhibited the absorption of sodium, we are going to accumulate a lot of potassium, so we have hyperkalemia. Other side effects, you can have carbohydrate intolerance. How does this come about? Because of the inhibition of sodium uptake. Sodium is required for the conversion of insulin into insulin. So if you do not have formation of insulin, you can have carbohydrate intolerance. Other side effects, you can have hypotension, specifically orthostatic hypotension. The contraindications, you are not supposed to use this medication in someone with end-stage renal disease or someone having bilateral renal stenosis of the blood vessels supplying the kidneys, because we will just decrease further the glomerular filtration rate, leading to a CKD or acute renal injury. Then it is also contraindicated in pregnancy because it has a teratogenic effect. So this is one of the classes, angiotensin converting enzyme inhibitors. Another class of medications that affects the RAAS is the angiotensin receptor blockers. For them, they do not work on the ACEi, but they work directly on the receptors onto which angiotensin binds, that is the type 1 receptors. So whenever they do not bind, whenever aldosterone does not bind onto these receptors, we won't have vasoconstriction, we won't have release of aldosterone. Therefore, we will decrease the cardiac output and the total peripheral vascular resistance. Some of the examples of medications here, the first one was losartan, the first medication. Then you can have valsartan. For them, they have a suffix satan. You can have telmisartan, and have candesartan. And for the side effect profile, for them they have a safer side effect profile compared to the angiotensin converting enzyme inhibitors. We won't be having a cough and we won't be having angioedema, because we will not be like the bradykinins will be hydrolyzed, because we are not affecting the angiotensin converting enzyme. We are not affecting the angiotensin converting enzyme. Though some of the other side effects, you can have hyperkalemia and also hypotension and other things. Then another medication that affects the RAAS is the renin inhibitors, and here we have only one medication, Aliskiren. I don't know whether I've pronounced that properly, but this is the medication. So for it inhibits the renin to convert angiotensinogen to angiotensin 1. If we do not have angiotensin 1, we won't be able to convert it into angiotensin 2. Therefore, we won't be having the effects of vasoconstriction, release of aldosterone, bring about sodium inhibiting sodium retention and other things. So basically, these are the medications that affect the RAAS.